Thank you, Louisa. That was... You can have me tearing up now. It is now my pleasure to introduce Professor David Thomas. David, in addition to being Louisa's physician, is also the Director and Division Head of Genomic Cancer Medicine at the Garvan Institute of Medical Research. He is also a conjoint professor at St Vincent's Clinical School in the Faculty of Medicine at the University of New South Wales. Please welcome Professor Thomas.
Well, it's a great pleasure to be here, and I'm incredibly proud of Louisa. As a human being, you've, it sets a sort of standard for the rest of us to live up to, I think. And that's essentially the problem that we were facing. Louisa didn't say this, but at the time we were having that conversation about what options were to happen next, she wound up in ICU the next couple of weeks. And I was seriously worried that the vanishingly short time that she had and that patients in her situation have was going to run out before I had any chance of being able to get access to what I thought was her best shot. And as is often the case for the diseases that I treat, and let's just talk about rarity for a minute. So the diseases that I specialise in are 1% of all cancers, and there are 50 different subtypes within that, which means that the idea of getting a trial up or arguing using conventional criteria of getting studies that would generate data for this group of patients, at least not in a useful time frame, remembering that in addition to being a researcher, you're a clinician and you're looking after people, it's just impractical, and certainly not practical for Louisa. It wasn't entirely randomly chosen. We've been watching in the oncology community the astonishing effects of these immunotherapies, and we don't really know why they work, but we see for the first time in my life as a clinician, I'm seeing the tail ends of those survival curves separate, and people have disease control for more than just a few months. And we don't know why or how to pick patients yet, but I figured that at the point that Louisa had failed her 5th line of chemotherapy within 9 months, and when I say failed, I mean the drugs failed her. That was the logical thing that we should be trying to do. And I based that on a whole lot of literature over 25 years that only somebody like me who specialises in nothing but these diseases could possibly know about. And so we took a gamble. And I think we had a very frank conversation because, where do you go to when you don't have any data to guide you? You have to go with your best instincts. I think the challenge for us as a community is to try and work out how to do that in a rigorous, data-producing way that will improve outcomes next year and then in 5 years' time, rather than saying it's all too hard and that 20% of people who get rare cancers and the 30% of people who die from those diseases, they're just too difficult. And so we'll fund the problems that are soluble, because the reality is that changes in science, and the science of cancer in particular, have changed in the past 5 years such that the challenges to the way in which we conduct our research in our healthcare system to try and to turn that into something that is useful to patients. Common diseases are becoming uncommon diseases. That should mean good things for rare cancers, because now the problem is not intractable. It's just a question of developing the tools to be able to generate the data that will ultimately satisfy the requirement to be accountable to the taxpayer, which I agree is important. So this treatment, I'm not sure whether it's worked yet, but I can say one thing, that Louisa was bedbound and in ICU in the week before we started, and it's been 9 weeks now, and she had a rough week a couple of weeks ago, but I think you were working 4 days a week. That's got to be productivity by anybody's standards, if we can get to that point. What we need is to do this on 10 people and then go back to the community and to pharma and say we should be doing this on 100 people, and there you'll have your evidence to take. I think the question is whether for people at this time of accelerating discovery, whether we should be bringing research in as a standard of care for those with unmet needs, and nobody has a greater unmet need than the patients who are dying from rare cancers in our community. There should be a mechanism that we provide an affirmative action to try and deal with this problem, where 15% of our drug budget goes to 50% of the cancer deaths in our community. There's got to be a way that creatively, we as a society, we don't have to solve the biology or genetics of cancer. We've got the drugs there. It's just a question of will. And I think, even if we start small and work our way big, I think we need to be moving towards that goal. And in the meantime, angels come to raise the 70-odd thousand that was necessary to do the experiment on which Louisa's life depended, and so far seems to be working. So thank goodness for angels. Thank you.